Mm.
Yes, sir, we are live. I'll share my screen. So you can start.
Yeah. Luka, how to go to the next slide? Okay, you will do that. Yeah. I will introduce Dr. Samir Melinkeri sir. Dr. Samir sir is head at the Department of Hematology and director in the Bone Marrow Transplantation Center at Dinanath Mangeshkar Hospital, Pune. Dr. Samir sir has completed his MD from BJ Medical College, Pune, and DM in Clinical Hematology from CMC Vellore in the year 2007. As per the publication is concerned, Dr. Samir sir has been author for many international and national publications and journals like An Hematology 2002, Annals of Hematology 2006, European Journal of Hematology 2001, The Lancet 2006, Indian Journal of Hematology and Blood Transfusion 2020, etc. As per the affiliation, Samir sir has been associated with Indian Medical Association, is a life member of Indian Society of Blood and Marrow Transplantation, and member of a scientific committee. Dr. Samir sir has been in the part of important conferences which he has attended in the last several years, like Indian Society of Blood and Marrow Transplantation annual meeting as a faculty from 2008 to 2021. Indian Society of Hematology and Blood Transfusion as delegate in 2007, 10, 2017, and 2018, and so on.
Well,
Like,
it's fine. It's
thank
fine.
you, sir.
You can
Yeah.
just go on.
Yes, sir. Rukia, can you please put for next slide? So welcome Samir sir, and now Dr. Akshay Shah sir is our one of the panelists today. Dr. Akshay Shah is a consultant medical and hemato-oncologist and BMT physician attached to Raheza Hospital, Mumbai and Global Hospital. Sir has completed DNB from Jaslok Hospital, and he has also completed his fellowship in stem cell transplant from Washington, USA in 2011. Sir has been member of American Society of Clinical Oncology and also with European Hematology Association. Dr. Akshay Shah sir has performed over 130 transplants, and he has also performed over 100 bone marrow aspiration and biopsies. Dr. Akshay Shah sir has been attended several conferences, workshops, and seminars in international and national levels. Akshay Shah sir, welcome for the Pfizer virtual meet. Rukia, next slide, please. So our second panelist today is Dr. Varun Wafna sir. Varun Wafna sir, welcome. Varun Wafna sir is practicing in Kolhapur in Super Specialty Hospital, and he's also associated with Sai Onco Surgery Center, Kolhapur. He's a chairman of Hemophilia Society of Kolhapur. Sir has been participated in many research, and he has specialized in stem cell transplant, cancer immunotherapy, adaptive T cell therapy, and CAR cell therapy. Sir has participated in many national and international conferences as faculty. Welcome, sir, in Pfizer meeting.
Thank you.
Rukia, next slide, please. Now I will introduce Dr. Ashok Rajoria, sir. He's another panelist today. Dr. Ashok, sir, did fellowship in hemato-oncology and bone marrow transplant from Dharamshila Narayan Cancer Center, Delhi. He has developed hemato-oncology and bone marrow transplant center at Apollo Spectra Hospital, Gwalior. He has been done autologous bone marrow transplant and multiple myeloma and Hodgkin's patients. All 4 patients has completed 100 days. He has more than 10 publications on national and international level. Sir has won many prizes like in MP Pathacon 2016. He has won the first prize. Welcome Ashok sir for the Pfizer virtual meet. Rukia, next slide, please.
Okay.
Rukia, I think the slide has stopped. Now another last panelist, Dr. Ankit Rayani sir. Dr. Ankit Rayani sir is a consultant hematologist at Query Hematology Oncology Center, and he's also attached with Sterling Hospital, Sal Hospital, and SCG MediSurg Hospital, Ahmedabad. Sir is a DNB hematologist from Sayadri Hospital. Sir has performed more than 250 autologous and allogenic bone marrow transplant for various hematological disorders. And sir has published poster and oral presentation in different national and international journal and conferences. Welcome, Ankit sir, on Pfizer's virtual meet. Rukia, now you can stop the slide, and I will take this opportunity to hand over this session to our moderator, Dr. Samir sir. Samir sir, please.
Hi, good evening, everybody. So I, of course, know Ankit and Varun well, but it's nice to know Akshay. I never, and Ashok, of course, and I never met you before, but it's good to know you. You know,
Thank you,
thanks
sir.
to Pfizer.
Nice to.
Okay, so the topic
Thank
for
you.
today's discussion is all about relapsed ALL. And I'll just share my screen just a minute. I'll share the presentation. Okay, fine. So the topic of the talk is transforming treatment paradigms for patients with relapsed refractory adult B-ALL. Okay. So question to all of you: how many patients do you see with adult ALL in a year, roughly, in your practice? And what is the proportion of those patients who relapse in your setting? So we can just go one by one. You can roughly tell me what your numbers are. Ankit.
Sorry, sir. Yeah. So
Yeah.
I usually in our center we see around 5 to 6 new patients per month. Many of them may be elderly and may not be eligible for curative therapy. But whoever is taken up for curative therapy, around less than 50% would see 1 year overall survival. Because of various complications and refractory disease or intolerance to therapy. So,
So one by one, you guys can just comment. So Varun,
Yes, sir.
Ashok, and then Akshay.
So I think around 3 to 4, maximum 5 patients in a month, what we see usually for the adult ALL. Yearly, roughly, what we see around 30-40 patients. And if we ask for relapse rates, around 5 to 10%, 10% around usually gets relapsed at the end of the treatment. Yeah, post treatment is in first 2 years of the maintenance. At present, I think we are and I think, sir, I'm not usually I'm not upfront. I'm not using a hypercivate most of the time. I'm going with the pediatric protocols. With just if he's more elderly, then we drop the asparaginase. The rest, I think, but I'm not sure what else other is using.
Sure. What about the others, Ashok and Akshay?
So in my setting, sir, I have started last 2.5 year this center hemato-oncology in MP Madhya Pradesh. At my
Okay.
place is my hometown Gwalior. So I have total pediatrics, adult and elderly patient is around 22 in the last 2.5 years. So
Okay.
around 7 patient is around adult more than 18 years, and all are my pediatric patients. So
Okay.
only one patient I have seen on maintenance 6 months. He She had relapse, so, and few patients, elderly patient not on follow up. So this is a scenario around like 7% total patient in my last 2 years in adult patient I have seen.
So, and what protocol do you usually use for your adult
So
patient?
usually adult patient, I am using only pediatric based therapy as a GFM
Sure.
95. Yes,
Okay.
modified
Fine.
protocol.
Okay. And so Ashok.
So I see about, hello, I'm Dr. Akshay.
Oh, sorry, Akshay. I'm sorry, Akshay.
So I see
Yeah.
around 8 to 10 patients of ALL, including about 5 to 6 of them are per year. I'm a medical oncologist and a hematologist. So,
Oh,
and
yeah, of course. Yeah.
so And most of them I treat with BFM 95. If they are elderly, then I give a little less aggressive regimen. I use either BFM 95 or R hyper-CVAD protocol.
Fine. Okay. Yeah, so I would agree with the. I also use pediatric inspired protocols for adults. I've used to earlier use hyperciphat for all those who could afford, and especially those who are a little on the younger side and those who present with high burden disease. But more often than not, I've stopped using hyperciphat and I'm switching on to the pediatric inspired protocols only, because now earlier when MRD was not standardized, we had no way of knowing, so we used to just go rather blindly. But now, since the last sort of good number of years that MRD has been established, we can always go by a little more less intensive protocol and monitor the MRD and go by that and decide whether you want to upscale treatment or not. Okay. So this is a systemic review published by the Vivek Rajakrishnan and Bhausai Bagar, etc., wherein it was a review of of the burden and treatment of patterns of adult and adolescent ALL in India. And here what they had found is, and you can see, the proportion of adults of ALL amongst adults diagnosed with acute leukemia at various institutions ranged from 7% to 57%. So obviously, depending on what sort of a center, if you are in Tata or a disease or center which focuses on malignant patients, then of course you want to see more percentage of ALL patients. But if you are in a center which is like a general hospital, you would have lesser percentage. And CR rates and the median overall survival for these protocols also was very, very varied. So that sort of tells us that that the treating doctors, the number of the patients, the protocols used, and the supportive care at various hospitals in India is very, very different, and therefore the response rates and the relapse rates also are very different in most centers. But bone marrow was the most frequent relapse site. This is what was diagnosed, and we all know that with age, the ALL tends to fare worse. This is just a depiction of the same thing. So my question to all of you now is, what are the diagnostic tests that you use in establishing a diagnosis of ALL? So we all know, I mean, we don't have to start off with PBS and bone marrow, etc. That we always do. You do a flow and you establish. So CD22 is always a part of flow cytometry panels at all institutions now. So I'm sure you will also be doing that. But after you have done this, what else do you do? So we can start with Varun, Ankit, Ashok, Akshay.
All are done CDC, bone marrow flow cytometry.
हाँ,
So we can
उसके
do
बाद
yes sir. Then do the molecular test for the high risk stratification for the high risk and molecular test something.
yes.
Yes sir.
What do these include? Meaning, what are you looking at specifically? My question is specifically directed towards the fact that I want to know whether all of you are also doing pH like ALL workup.
So not
I mean, we always send fish. That fish and karyotyping we all send. Karyotype often turns out normal in ALL because the cells don't grow properly for some reason. Fish we always do. But beyond fish, are you also doing a pH like ALL workup? I want to know from all of you.
no sir. I'm not routinely sent for this only specific pH like workup.
Okay. Anyone else does it?
So,
Okay, so I'll tell you
sir,
some.
we routinely
Yeah,
do
yeah, Ankit.
Oncoman panel. Yes, sir. So we
Oncoman
routinely
panel is
do,
what?
especially it's a mutation panel, DNA mutation panel. And if the cytogenesis is normal, then we also do a RNA panel. We usually preserve the RNA, separate it and preserve it. If
Yes.
the fish is not able to pick up any translocation, then we also do a RNA panel.
So supposing fish
DNA
picks
we
up
routinely do.
pH, supposing fish picks up pH positivity, then
Right.
do you do the RNA panel or not?
No. The only thing that we like to do is actual pH chromosome translocation. So that we routinely do.
So supposing, okay. So, um, so at our place, we have been doing, I mean, we don't do RNA sequencing. We have a different way of diagnosing the pH positive errors. So we divide the mutations into, some of the pH like some the mutations like ABL1 rearrangement, Jack rearrangement, and some others. These are all done by fish. We have established it in-house. And the others we are doing by a method called MLPA. So we are not doing RNA sequencing, but RNA sequencing can also be done. And based on that, you will know whether the patient has and additional genetic mutations which can confer, a poor pattern like a pH positivity, and whether, that will confer a worse prognosis. So we have picked up other mutations like, IKZF is quite common. We picked up CDKN2A, which is another like important mutation, which, can confer a worse product. So for example, if you have a pH positive patient, not all pH positives do equally well. So some pH positives do well, they go into MRD negativity and they don't relapse, but some of them do poorly, and some of these have these other mutations positive. IKZF is common, CDKN2 is another common, there are others also. So if these are also additionally positive, like 2 3 of these are turn out positive in a pH positive ALL, these are the patients, especially in adults, where I would be keen to transplant them and not leave them alone with only chemotherapy. Because they have a much higher incidence of relapse. So whenever possible, these patients we tend to offer transplant, especially if they don't achieve, like a more than MR 4.5 or MR 5 at the end of consolidation. So I think that it's important that you should start looking at these mutations, and we do it even in the poor patients. Some of them are actionable. For example, if you see a ABL1 mutation, you'll have to add on a tyrosine kinase inhibitor. If you see a JAK rearrangement, you'll have to add on Jakavi. That helps. Right, fine. So, so these are the diagnostics that are usually recommended: blood test, bone marrow, immunophenotyping, genetic testing. This may identify genetic abnormalities and help in classification of ALL subtype and provide prognostic information. That's the one that we're talking about. And other tests like lumbar puncture, CSF, of course, this all of us always do. What is the percentage of patients that will relapse within the first year of diagnosis of B-ALL, and what is the most common site of relapse in your practice? So we can go in the same order. So Varun can start, then Ankit, then Akshay or Ashok, and then Akshay.
Sir, around I think 20-25% patients get usually relapsed for the adult if they are coming with a high risk. And the most common site again is the marrow only. Usually what we see, CNS relapse is also there, but more common marrows are usually what I see.
Ankit?
So,
rough percentage of patients who relapse.
Yeah, so I think 15-20%, same number. Those who we can stick to the schedule. There are some patients who are difficult, especially females in late middle years. So in those patients, it's very difficult to stick to the schedule, and those patients relapse rates are much higher. But if we continue with the schedule, BFM protocol, and at the end of intensive phase, once the patient is shifted to maintenance, that is the most crucial time where we see the early relapses, and that is around 15-20%, and marrow relapses are most common.
Yeah, so I agree that the relapses are much more common in maintenance than they are in the initial treatment. But I didn't know about the middle-aged females. I always thought that the AYA is a category, the adolescent and young adults. That is a special category now because they have all these issues. They have a lot of compliance issues, psychological issues. They are different. They are different for an adult to understand adolescent. Their thoughts and their processes, because we are all one generation apart. And that is the reason why that is a separate category. But I didn't know about middle-aged females.
So it's very difficult. I don't know why, but it's very difficult to let them comply with the treatment. So they always tend to come late or delays in. Even tolerance is also less. That is what I have found.
So, yeah, interesting. What about Ashok?
So, sir, in my practice, at least I have only 20 patients right now.
Yeah,
Till,
so I can understand. It's a small number yet. You just started.
Yes, only one patient had relapsed. 3 girls, like complete induction, consolidation, reinduction, and 6-month maintenance. Then she relapsed. Bone marrow is the site. Yes, sir.
Okay, fine. So that's a good number for your initial practice. That kind of a number is quite good. Yeah,
yes,
Akshay?
About 20% relapse, and the most common site is the bone marrow.
Yeah, I also would agree with what is being said. Okay, so now this is a paper which is Antra has pulled out and sent it to me, but this looks like pathetic. You're saying that after the first relapse, 5-year overall survival is 7%. I'm sure it's not that low. Maybe she's picked up one of the really worst presentations, worst sort of sort of series and send it, but it's not. I don't believe that it is a 5-year overall survival of patient with first relapse is 8%. I don't think it's that low. It's surely better than this, but trying to show that, even in advanced countries, the overall survival of a relapsed ALL, if you look at it after 5 years from the diagnosis, is not very good. I mean, it tends to, initially you may think that, in the first 2 years, first 3 years, everybody's surviving. You're very upbeat, but as you look 5 years, 6 years down the line, many of them tend to have late relapses. They have other complications secondary to transplant they may have undergone. So overall survival at long-term survival is not excellent. And of course, relapsed refractory ALL survival is dependent upon salvage therapy. So all those, so those who achieved a CR will always do better. Those who don't achieve will not do all that well. And those who are able to undergo transplant have a good survival. Those who cannot undergo transplant, the survival is quite poor. Okay, now this is the NCCN guidelines for ALL, relapsed refractory ALL. So you can divide them into pH positive and pH negative. Those who are pH positive, please remember that before you start treatment, you must look at the look for a kinase domain mutation. You must do an IRMA and see whether the T315I mutation, which is like a pretty common mutation in pH positive ALL, whether that is there or not. Because if that is there, then you know that you may have to add on a specific TKI, ponatinib. So the treatment would involve TKI plus chemotherapy or blinatumomab or inotuzumab or a CAR T-cell therapy, right? And those who are pH negative, you will do a molecular characterization in MRD if not done previously, and then they will enroll them either in a clinical trial or blin, inotuzumab or CAR T-cell therapy or chemotherapy. All these are options. And subsequently, once you get them into an MRD negative state, you're going to consider transplant in all patients as much as possible. Is there a category of patients where you don't where you don't advise transplant? A patient who is relapsed with ALL, what are the situations where you would advise only chemotherapy and not a bone marrow transplant? What is your protocol? Start with Varun. Varun? There's some problem. Maybe Ankit?
Yes, sir. So I cannot think of any specific subset, but if the patient had the initial therapy, which was pretty interrupted, and the patient had late relapse, and that too only CNS relapse. So in that case, I can continue with BFM relapse protocol along with intrathecal therapy and radiation.
Sure.
But I cannot think of anything else which can forego the transplant.
Sure. What is your policy? Ashok, are you there?
Yes, sir. Yes, sir.
Yeah.
So, in PH, sir, your questions and forget it.
The question is basically, is there which are the patients where you don't consider a transplant after after they relapse? So you would want to treat them only with salvage chemotherapy without considering a transplant. Is there any category of patients where you prefer this?
So, sometimes I just feel that not all patients are some more much affordable and financially so much of issues. Yeah, some patients is so many of comorbidities and all. So I just don't advise transplant. Yes,
Sure.
sir. I just treat with chemotherapy. Yes, sir.
Akshay?
The pH negative patients late relapses, we
Yes.
may consider non-transplant. Otherwise, usually we will consider transplant.
Yeah, I agree with you. So the pH negative late relapses and the extramedullary relapses, especially isolated CNS or isolated testicular relapse, those you can consider. The cure rates are are pretty good, between 30 to 40% with only a salvage chemotherapy protocol. So that I agree with. So transplant, otherwise, in general, is the only curative option available for relapsed patients. It's important that you get them into a good remission. So, what is the goal of treatment in adults relapsed refractory B-cell ALL, in your opinion? So, I'll kind of answer this question, and these are the three goals that you want. You want to achieve MRD negativity at all costs. So that's less than 0.01% on flow cytometry. please be sure that the lab that you are sending the flow cytometry to is reliable. You're confident. You've sort of tested it. Don't send it to any random lab unless you're very sure of what they're doing. Then the best treatment in first salvage status is what you want to give. You don't want to waste time with something that the patient is unlikely to respond to. And a high disease burden patients, you want to give the best treatment. And HSCT ultimately is your curative approach. These are going to be your goals: to get them into MRD negativity, give with the best possible treatment, and transplant them to achieve cure. Okay, now coming to MRD negative, CR here first, and then MRD negativity. So, as those who achieve CR are obviously going to have an excellent response as compared to those who don't. And MRD negativity also, if you achieve that, then that's the time when you can actually get the transplant. They have a better response after transplant. And so this is regarding the Innovate trial. Innovate trial is the one where which studied inotuzumab in ALL. And here, these were the CR rates and the MRD negative rates with inotuzumab compared to salvage standard chemotherapy. So the other arms, there were about 3 chemotherapy regimens that were permitted on this protocol, the standard ones, and the response rates for inotuzumab were far better. Yeah, so by end of salvage, this is the percentage of patients who achieved MRD negativity in first salvage. And MRD negativity was achieved in majority of responders within the first 2 cycles of inotuzumab itself. So as you can see, majority of them achieved responses within the first 2 cycles. And although patients were allowed to take more cycles, most of them achieved it within the first 2 cycles itself. Okay. So we'll come to a little discussion on the inotuzumab a little later. We just go through the data first. And MRD negativity was associated with an overall survival benefit in patients treated with inotuzumab. So as you can see, patients who are with the overall survival rate is definitely superior for patients who have received inotuzumab. And this is the PFS also showing significant improvement with inotuzumab. Okay. And survival was improved in MRD negative patients treated with inotuzumab was best, was even greater in the first salvage. So if you're using inotuzumab, use it in the first salvage rather than waiting for the patient to relapse again after standard chemotherapy, and use it in the second relapse. In second relapse, the responses are going to be poorer. That's logical because the disease is going to be more mutated and more resistant. So prefer to use it in the first salvage is what the message is. And achieving MRD negativity and receiving HSCT was associated with improved survival, and that is quite common that we all know. The adverse reactions to inotuzumab. So I don't know how much of inotuzumab each of you has used, because some of you are quite young into your practice. I've used a good amount of inotuzumab, and I can tell you that I haven't faced any adverse events so far, apart from the BOD part, which we will discuss. Most of the cytopenias that you see and the infections that you see are not related to the drug per se, but they are all related to the primary ALL itself. If you've got a relapsed ALL, you're going to treat with inotuzumab, you are likely to develop some cytopenia, some infections. So I believe it is more often the disease per se rather than the drug itself which causes all this. And of course, the most important toxicity that all of us know is the increased incidence of veno-occlusive disease or sinusoidal obstruction syndrome that happens in patients after transplant. The incidence of this is about 20%. And before you give each dose of inotuzumab, it is important to check the LFTs. Each week. So we typically give it for week 1, 2, 3, and skip it in the 4th week. That's one cycle, and then again repeat the same cycle. Before each dose that you're giving, you must look at the LFTs. So the incidence of SOS is quite less. I mean, the LFT derangement is quite less if you're just with just inotuzumab itself. The incidence is about 3-4%. But when you use it post transplant, where the liver gets hit with whatever conditioning regimen you use, that's the time when the incidence is as high as 20%. Okay. Now coming to, we all know we have to achieve MRD negativity. What is the best way to achieve it? So in your opinion, what therapy is likely to best yield the best outcomes in adult relapsed refractory ALL when offered in first salvage? So you have all the options. Let's leave apart CAR T cell therapy at the moment. That's on the horizon, but not yet there. So we'll not talk about it. But so if you have a patient who's come with say relapse within the first year of diagnosis, maybe relapsed in the first year of maintenance or at the end of the first year of maintenance, then do you routinely prefer salvage chemotherapy? In that case, which salvage regimen do you use? Or do you prefer LIN, or do you prefer inotuzumab? The inotuzumab, I don't know if you any of you has used. I've used it about 7 times so far. But in which patients would you theoretically prefer each of these? We can start with Varun.
Sir, usually fine, I think we can go with inotuzumab, but I have used it, sir, personally, actually, now, because finance is a big concern here. I usually go with hypercivad or REZ or 3 protocol present for relapse patient and then followed by the transplant.
Hypercivad, which other did you say apart from hypercivad?
R3 or REZ, sir.
Okay, sure.
BFM
Fine.
R3, sir.
Sure. I get it. Ankit?
Sorry. So in patients who are late relapses, then I try to do hypercivad or BFM relapse 85 protocol without induction, starting from R1, R2. Because induction, I think none of the adults would be able to tolerate and go through it. So, and in patients who are affording, definitely if CD22 is positive, then I know is one of the good option. In if it is negative and if the patient has tens of lakhs of rupees, then Blina would be an ideal option. But then I've never used blinatumomab. I've used inotuzumab till now.
Okay. Ashok?
So, sir, only just the late relapse at the relapse setting, if the patient affordable, really, I just gave inotuzumab offer the patients. So, I only one patient's uh, got a right now, she relapsed on maintenance. So already she's taking so much intense chemotherapy, so many of complications during the induction and all. So I just offered this inotuzumab, and she received one cycle right now completed, and she's fine right now. And one of my patients, elderly 76-year-old male, and ALL CD22 positive. Uh, so I just start with the apparent inotuzumab, 2 cycles. So because of he's a diabetic, he's a hypertensive, so many of things. So doesn't give any other chemotherapy option. So I just give it inotuzumab, and he's fine with on 1 year. After 2 cycles, he develops some hepatotoxicity. So
Okay.
after that, I don't give third cycle and fourth.
Sure. Okay. Akshay?
So usually we'll give the option of inotuzumab, but very few of them are that affording to use it. We use usually our hypercivad plus minus TKI or high risk arm of BFM 95.
Okay. So I agree. So, I'll tell you something. If you look at my experience over the last several years, if you're going to use hypercivad or flag, that is another regimen which I commonly use. Generally about 2 cycles of flag to get them into MRD negativity, or hypercivad cycle 1A, 1B, and sometimes cycle 2A, 2B. I can tell you that the cost of treatment works out to be the same, or maybe even possibly cheaper for inotuzumab. Why? Because with hypercivad, sometimes they go into severe neutropenia, develop sepsis, and then the cost of treatment can escalate to several lakhs. Especially if you're in a corporate hospital, then the cost of treatment can be very high based upon if you're going to use antifungals and you're going to use high-end antibiotics and a stay of something like 2-3 weeks. But the morbidity is different thing, but the stay itself is going to be pretty high. And compared to that, inotuzumab, now they give 2+1 whatever dose. So with that, the patient is taking it on OPD basis. There's no admission, nothing at all, and the cost of treatment is not very different. The only situation where it can be different is probably if the patient, of course, goes very smoothly through his salvage chemotherapy, or if you're going to use. So in those patients who have a late relapse, those patients I tend to use vincristine bortezomib induction based induction with without asparaginase and steroids. And then so basically I'm using the same BFM protocol once again. And some of them, if they're late relapses, they can go into good remission. Those are early relapses, of course, I won't go with this. I would prefer to give inotuzumab. And those patients where, so inotuzumab, the only issue is going to be the 20% risk of VOD post-transplant. In that situation, the ideal drug to give is blinatumomab. But blin will work best if you have very minimum disease. If you've just got a little bit of relapse, you've been monitoring the patient and the MRD is just positive, or the 10% blast, 20% blast without a high burden disease. Those patients respond beautifully well to blinatumomab. But and blin, the good thing is that is no the toxicity is if you leave apart the ICANS and a little bit of CRS that can happen in the beginning, that is the only toxicity. Otherwise, it works. It's a beautiful drug. The problem is that it is the worst drug ever to administer. Worst drug ever to administer because it is very, very cumbersome. The drug has to be is very expensive, of course, and so every ml is important. And then you're taking one from a little bit from one vial and then transferring, waiting, keeping a little bit in the other vial, calculating the dose, and it has to be given as a continuous infusion without any interruption for 28 days. Then you give a gap of 2 weeks and again another cycle of 28 days. So the patient is essentially wired to an infusion pump for like 2 months. And it is plus the specifications of giving it through the specific there has to be a specific sort of syringe material which we have to use. The infusion pump also has to be of a specific make. So if you don't have that, then it's not possible to give blinatumomab. So it's a very difficult drug to give. But if you have minimum disease and if you're going to plan transplant, that's the best drug to give, surely. So
sir,
in all
one
patients,
question.
yeah, Ankit.
Yeah, sir. So whether we can give blinatumomab if the patient is lymphopenia? So there was one question. Use it to X by engaging T cells. So if it is patient has just undergone
No.
salvage
So,
chemotherapy.
yeah, you can very well give it. So
Okay.
thing is, even if you're thinking of somebody who's got a lymphocyte count of say 5%, and everything is, rest of it is whatever, neutrophil, whatever. So that 5% is a huge number of lymphocytes present in the body. It's enough to catch so of course you have to make sure that you don't have a heavy disease burden. Otherwise, blin doesn't work. If you have a very high burden, it won't work. So you'll have to give some, like steroids, vincristine or bortezomib, something like that. Get the majority of the blasts under control, and then you institute your blinatumomab. So that is what is typically done. But we don't talk too much about lymphopenia when you're using this. There'll be sufficient number of lymphocytes, and lymphocytes are going to constantly keep generating. So if you have one set of lymphocytes which is killing the blasts, then the lymphocytes are going to be constantly being produced also. New lymphocytes are going to get produced. So they are going to constantly help in killing engaging the blasts.
Right.
It's not like a finite number at one point of time. Okay, so I feel is like a fantastic drug. It's like a boon that's come for us. Something which can be just given like as a drip in the OPD. I don't even admit. You don't have to admit your patients, and it takes care of reasonably high burden disease also, as you will see in the next few slides. Okay, so this is again CR and MR based on negativity. This is all common sense, and you all know this. Overall survival is based on the line of salvage. This is also we kind of know this. I also won't waste time on. Okay, yeah. So those who are on inotuzumab were more able to go into transplant as compared to those who received standard chemotherapy. So 52% in salvage 1 and 39% in salvage 2. They would actually undergo a transplant, where the numbers were quite small for standard chemotherapy, right? Yeah. So if somebody has a high burden disease, like blast count of more than 50%, or blasts coming in the peripheral blood in large numbers, then in this case, what do you do? So inotuzumab in general, as compared to standard chemotherapy, even in high burden disease, it works quite well. That is more than 50% blasts within the marrow. We're not talking about in the blood. So if you have like a 1 lakh count in the blood, then please don't use your inotuzumab directly. Okay, in that case you must use some other chemotherapy to get rid of most of the blasts, get the disease down. So something like a pre-phase, get the majority of the blast down to, at least a basic minimum in the blood, and if possible, whatever number you can sort of get rid of in from the marrow, and then use your use inotuzumab. That works better. So many people combine inotuzumab with chemotherapy. The chemotherapy comes initially, and then you use your inotuzumab. Yeah. So in the marrow, those who had a bone marrow blast count of less than 50%, 50 to 90%, more than 90%. Again, in the inotuzumab arm, majority of them could actually proceed to transplant, whereas in the standard chemotherapy arm, very few could go into. This, of course, is a small number of patients, so it should be interpreted with caution. And considering the veno-occlusive disease, so here again, that is roughly about the same. So it's not very different depending upon what number of blasts you have. The veno-occlusive disease doesn't matter because it's drug specific, it's not disease specific. So inotuzumab improves survival irrespective of the bone marrow blast count, and that's not true with blinatumomab. Okay, so this is an extramedullary disease or a lymphoblastic lymphoma. And here again, the same thing translates. Inotuzumab again is far superior to standard chemotherapy in getting the patients into CR and MRD negative state also. Safety profile was similar at all bone marrow blast counts. This is all okay. So the febrile neutropenia is high with a high blast count, but that's related to the disease biology, not so much of the drug itself. Okay. Yeah, so this is what I just mentioned. And important, so what is the long-term overall survival in your treatment setting? I don't think this is a good question because two of you are quite young. Ankit and Varun are older, but long-term overall survival in your setting, I don't think any of us is. Do you have any rough figure which you want to quote?
I don't think I would be able to accurately say that. So in patients who have relapsed, it would be maybe 30% or less, even less, especially in adults.
Yeah. Varun, yours?
Yeah, so same around 25, 30. I'm also not sure. Most of the time we lose patients are in the, as you told, in all the chemotherapies and
that's
that.
right. That's right. I mean, only those who can actually undergo transplant, they are the ones who may survive. And even out of those, the rough cure rates are in the 40-50% range is what I would say. But the rest of them don't make it. Long-term overall survival, even in the Innovate trial, is not fantastic. So it's about 20%. Okay, so what you're saying is pretty okay. And for treated patients, those who achieve CR/CRi follow-up HSCT versus no follow-up HSCT, again, those who are able to undergo HSCT obviously had a much better chance of survival. What is the commonest adverse event in your experience? Anything else? Anybody else has to share any abnormal adverse event that you faced apart from the common ones that we've discussed?
So only one of my patients, after 2 cycles, receive only hepatotoxicity, not as such a BOD, but also same hepatotoxicity. Yes, sir.
Okay, so like
Otherwise, as
elevation
such,
of enzymes.
yes, sir. Only just
Okay.
elevate the enzyme and some kind of thrombocytopenia, but after that, few 7 days, 10 days, both patients are recovered with this
Sure.
thrombocytopenia. Yes, sir.
Sure. And incidence of VOD and tragedy, I'm sure that this is not a question which we should be asking us because we're not used enough, I would say. But for those patients who I have faced, who have taken up for transplant after inotuzumab, I would have probably taken up maybe about just about 5 or 6 patients post into transplant, or maybe slightly more. I can't remember. But one of them had a really, really bad VOD. We used only a single ventilator in that patient. We used triosulfan. The patient has a horrendous VOD, and he died of the VOD only, I would say. So the VOD can be sometimes terribly bad. And we use defibrotide in that patient. The cost of defibrotide is more than the cost of transplant. It works up to something like 20 lakhs or so for defibrotide. So that can be quite bad. So in those patients who have received inotuzumab, I prefer to give an alkylator-free regimen if possible, and that would be fludarabine with total body irradiation. That's the protocol which I prefer to use. Or if they sort of already, if they're not, if you don't want to use TBI, if you don't have it available at a center, then please use only a single alkylator So I don't use a dual one. So don't use like triosulfan, with, so if you're going to use PTCY, for example, many of the times we do haplotransplant. So haplotransplant, post-transplant cyclophosphamide is always used. So if you use triosulfan and then you're going to use cyclophosphamide, that's like a dual alkylator. So then you're going to increase your chances of VOD. You understand? So try and use only flu TBI or some such TBI-based regimen if you're going to do a transplant after inotuzumab. Okay, this is all side effects. Yeah, so a long-term follow somewhere around 20% patients developed VOD as compared to standard chemotherapy, where the incidence was much less. Rates of VOD and how to prevent VOD is more important. So dual incorrect alkylator, dual was single. So look at the pre-HSCT bilirubin levels, and if that is very important, if that has to be sort of normal before you use to do the transplant. And a prior history of liver disease, again, that is very important. Somebody who's got existing liver disease, try and avoid inotuzumab. Maybe there you would use some other agent. Development of SOS in inotuzumab cycles. So always restricted to 2 cycles. Don't use more than 2 cycles if you're going to transplant a patient. And after every cycle, you must check your bone marrow MRD. So at the end of cycle 1, if you have bone marrow MRD is negative, which I have seen in a couple of patients, then I would directly transplant after 1 cycle. But otherwise, I would use 2 cycles. Make sure you check the bone marrow MRD after every cycle to minimize the amount of inotuzumab that you give pre-transplant. Yeah, and this is again, if they develop VOD, then you must make sure that you monitor the patient's weight, look for retention, just treatment of VOD, of course, monitor the LFTs, monitor the all these before after each inotuzumab dose, as I had mentioned, that adjust the dose as recommended. And was proceeding closely monitor LFTs during the first month post HSCT and then less frequently, because it can happen between 2 to 3 weeks after transplant, but it can sometimes you can have a late VOD also. Cost burden I was mentioning. So you can do this exercise and check and see if you feel hypercVAD is cheaper. Then that's a wrong impression, because hypercVAD involves significant admission, significant antibiotics. So I think sometimes that the inotuzumab is so much less morbid that I really prefer using that in there. And sometimes you can get away. I told you can get away with 1 cycle only. So you're giving only 2 doses of inotuzumab as compared to significant like 2 cycles of flag or hypercVAD or whatever. So you can consider that. So mean hospital days were of course lesser, and this is all quite obvious that the admission hospitalizations is much lesser. Burden of hospitalization has been mentioned, and I can tell you that it is significantly higher when you use standard chemotherapy. So a little bit of ASH EHA 2021 updates, and this was outcome of RRBALL with extramedullary disease receiving inotuzumab, real world retrospective study. And just to sort of cut it short, the outcomes were roughly roughly similar. There's not much of a difference between what you see here and what you saw in the Innovate study. Real world evidence demonstrated that inotuzumab was an effective treatment in patients with relapsed refractory extramedullary ALL and poor prognosis, including successful bridge to transplant. So roughly the data is the same. Yeah, so as you can see, around 42% of patients experienced a CR within 1 cycle itself. Yeah, and the 1-year OS and the 2-year OS is roughly this much. So treatment with inotuzumab is an effective and promising approach in these patients. Allo-HSCT does not appear to be an effective consolidation approach for maintaining disease control, and results should be interpreted to consider a very small sample size. Okay, so I forget about this. Okay, so with that we come to the end of today's discussion, and you are free to ask any questions, or if you have any any pressing question that you want to discuss, we can always talk about it.
So my question, sir, I asked someone question, sir.
Yeah.
Hello.
Yeah.
So after giving a 2 cycle MRD is negative, so how many more cycles to give the patient if patient not want to go transplant?
If you don't want to go
How
for
many?
transplant, then there is no answer. You can give it depending upon looking at the LFTs all the time, looking at the patient's pocket. Then there is no clear answer. You can give it. You can give it up to 1 year also.
Okay. Thank Thank you, sir.
But
Wonderful.
I know those. But we haven't looked at the long term data of those patients who are treated without transplant with only inotuzumab. So we really don't know.
So, sir, yes, sir. Sir, what do you use for resistant or patient who was not able to tolerate?
Who's not able to tolerate inotuzumab?
Yeah.
Then if Blin is possible, Blin. Otherwise, standard chemotherapy. So
And
any of these. And currently
right.
we have a CAR T-cell trial going on. So
Okay.
so hopefully CAR T-cell will come soon. So we are doing the Immunact study
Okay.
for CAR T.
Right, sir. So have you used venetoclax combination in with intensive therapy?
I have not used for I have not used. Have you used it? You can share your
I've
experience.
used in one patient who was I think 3 or 4 therapy failures and refractory, primary refractory disease, ALL, young
Sure.
ALL, 18 years, 19 years old. And I gave a plague without IDA and followed by venetoclax 100 mg OD for 15 days. He went
Yes.
into remission, but then once we took him for transplant, I don't know why, but he had very bad, very severe, worst kind of GI bleeding with the effect of TBI. So I used flu TBI for him. But then
Yeah, that's possible.
ultimately he
Mucositis can do
succumbed. I don't know what happened, but then he went into remission at the end of salvage chemotherapy. So that was one of the papers that I saw, combination of venetoclax with high dose chemotherapy for primary refractory or relapse patients.
Sure. Yeah, I know that that combination exists, but I'm scared to use it because I'm scared of venetoclax in general.
Right, sir.
It is like venetoclax is now like the typical lakh dukho ki ek dawa. But
Yes, sir.
It's very difficult, very toxic on long term for that, even
but
for
it is
AML.
toxic, man. It is worse than chemotherapy sometimes. Sometimes, I mean, because I don't know how somebody can tolerate 400 milligrams of venetoclax. I've rarely seen somebody tolerating that. So that to combine with flag requires guts. I would say.
No, I used only 100 mg, and then patient tolerated very well. That went very well, but then ultimately during transplant, I don't know what happened, but that we could not even stop the bleeding. So some kind
But
of
that is not related to your venetoclax or flag. I think that must be whatever
maybe
mucositis.
TBI gone wrong because
Wahi
I don't know what happened.
So after this inotuzumab, how VOD before transplant, we can just any prophylactic defibrillate we can use to avoid or decrease the chances of VOD. Anything specific?
Theoretically, you're right, but the insurance 20%. As I told you, the cost of defibrillate is about more than the cost of your transplant. Even if you use it in the prophylactic dose, it's like very, very expensive. So best thing is to avoid alkylators and make sure that the liver functions before the transplant are like extremely good. You can even consult a hepatologist if you want to confirm that that is the case. And if that is there, then only you use it. Nothing
So
else
in
that you can
Narayana
do.
in Arena for Thal kids, we used to use N-acetylcysteine.
Yeah,
Really,
that's a good
how it
idea.
helps?
You can try that. You can try that. You can surely try that. No harm.
Okay, sir.
Fair idea, I think. Okay, fine. So what else? What else do I want to discuss? Yeah, I think that's it. We have to all wait for CAR T cell therapy to come into the horizon to become routinely available now. Imminently, the Immunil product is going to come, and then surely next year probably the other one will also come, Immunoacts. So then we'll have to really compare and see how well they work. Because one other important thing I want to tell you is that if those patients who have CNS disease, so both blinatumomab and inotuzumab do not penetrate well into the CNS, so you cannot use it for CNS disease. CAR T is only one which can penetrate the CNS. but that's one area where you have to use chemotherapy only. So you can use inotuzumab for for taking care of the extramedullary for the medullary disease, and simultaneously you'll probably have to also give additional CNS directed therapy because it doesn't doesn't penetrate the CNS well. Fine. Okay, so I think if that's that, any other questions? Ankit, then you want to say something?
No, I think
Okay.
it would be all.
Okay. Pfizer, do you want us to discuss anything specific for you? You're on mute. Vimal, you're on mute.
Sorry, sir. No, sir. Thanks for the wonderful discussion. If Rukia, if you get any question in the chat box from attendees, please you can ask here.
Yes, 1 second.
And nothing else, just insight from all the panelists, sir, if possible. Just a 1 minute insight from you on inotuzumab and this disease area. If you can please tell something, sir.
There are a couple of questions. Can I put them in the chat box?
Yeah,
ask
please,
direct.
please. You can ask that, Rukia, or okay, just a second. Let me.
Yeah, 1 second.
You can put on chat box. I will ask.
Yeah, okay. So there's first question.
So, sir, there is first question that asking, do you give HDM-TX pre-SCT if inotuzumab brings remission in induction failure?
Okay. So the question is, supposing there is induction failure. So you've given, say, BFM protocol, and at the post-induction, the post-induction, pre-SS. So in extramedullary disease. Okay, so you will have to. So if there is CNS involvement, see, if you're going to do a transplant, the question is that if you're going to do a transplant, then transplanted cells, so only cells penetrate the CNS extremely well. Okay, apart from chemotherapy, the transplanted donor cells can penetrate the CNS and take care of CNS disease. So if you don't have CNS disease in the beginning, and the patient has sort of relapsed, and you've given inotuzumab as induction, then you will probably not have to do high dose methotrexate, because you don't have to additionally take care of the CNS disease if there is none. If there was CNS disease to begin with, then you will have to give some CNS directed therapy, whether you want to use high dose methotrexate or you want to give cranial radiation followed by triple intrathecal therapies to get the disease under control. That is fine. But if you didn't have it, then probably just inotuzumab followed by transplant. Sorry?
Sir, one of my hello, sir.
Yes, Ashok.
Sir, one of my patient, he CH positive ALL, and this is the age of 32, 33-year-old. I start the paglastatinase for after that around 15-20 days. After 15 days, he had a traumatic event. The whole lower limb is right side is fungus. So all with DBT is developed. So can we reuse re-challenge with this drug after 3 and 4 months?
You can re-challenge with with thromboprophylaxis if you are very keen, but in a pH, if you are a pH positive ALL, I generally avoid asparaginase in the first place. If it is if it's pH positive. Sorry. Okay, so I think I was on mute. So if you have pH positive ALL, avoid using asparaginase in the first place, because you can do well with the TKI and just develop steroids. So you probably don't need the pegasparaginase at all. But if in any other sort of pediatric setting, or where you want where we are very keen to give the asparaginase, then you'll have to give it with thromboprophylaxis.
So any the pH positive patient ALL start with the transplant. So how should TCI is using continuous dosing or
So your voice is cracking a little bit. Can you maybe come a little closer to the mic and speak?
Hello. Yes, sir.
Yeah. Now it's perfect.
Maybe, sir,
I think, sir is rejoining.
Okay, sure. So I will just continue the second question. Dose in practical setting of inotuzumab. Dose in practical setting of inotuzumab. I didn't understand that question clearly, but so it's typically 1.8 milligram per meter square. That's the total dose over 3 weeks. So that's how we do it. But so we can probably round it off to 1 milligram. If it's coming just close to that, I tend to practically round it off. If that's the question that is being asked, you need not just use a new vial for a little bit of more inotuzumab. I think most of the times you can round off a
I
little.
think the question is whether we can equally divide 3 doses. So it's a graded regimen. So that must be the question. So to utilize the vial fully, whether we can do 3 equal dosing of 1.8.
Sometimes you end up sort of adjusting, I think. So
Right.
we'll have to probably see what it's coming to, and then apparently round off a little bit. Nobody knows the real answer. And I always sometimes, I mean, not always, but sometimes believe that the doses that are recommended by the often you can make do with slightly lower doses or adjusted doses. I don't think it matters too much, if you ask me, the real world practice. And inotuzumab in extramedullary disease in CNS, it doesn't work well. Everywhere else, it will work well.
So one bortezomib-based regimen has for one paper I'm reading bortezomib and associated decrease of fighting agents and DEXA was there. I will share the paper with you.
Just say once again.
Bortezomib-based regimens.
Varun,
Based regimen for relapse ALL.
Varun, can you just
Can you hear
maybe
me, sir?
switch off? No, it's cracking up quite a bit. Maybe you can just switch off your video and just see if your bandwidth is probably a little lower.
Sir,
Now you can talk.
yeah, bortezomib-based regimen for relapse ALL.
Yeah. So bortezomib regimen for at least I typically use bortezomib weekly and vincristine weekly. So it's like on a Monday if I'm giving bortezomib, then Thursday I'll be giving vincristine, and that way for 4 weeks, and at the end of 4 weeks you assess the response and see, and then subsequently you can even continue the bortezomib through your phase 2 induction, or you can add borti to flag. Some people add borti to flag if they're using that. So various combinations of bortezomib.
Okay, great, sir. Yeah.
Yeah. Okay. Ashok, you were saying something?
Yes, sir. Sir, my question is ki pH positive ALL patient start with BFM induction with TKI. So, sir,
Yes.
how continuously this TKI therapies on full induction, or sometimes patient is very cytopenic and all. So I'm just worried about that.
Yeah, good question. But I can assure you that the TKI is more important than the chemotherapy in pH. If on a weighing scale, if you want to say, I would say the TKI is more important. So I do not stop the TKI, irrespective of the blood count. I just got maybe you can reduce the dose. Like dasatinib, if you're using, I just use 50 milligrams. Sometimes even lower you can use, but make sure that is going throughout your treatment.
Okay, sir.
And you can interrupt the chemotherapy, but avoid interrupting the TKI.
And sir, what about the maintenance therapy after finishing the treatment? Then maintenance with TKI.
Yeah, so that is an unanswered question. Nobody knows how long the TKI has to be continued after chemotherapy and after transplant. That answer is unanswered. Some people just give it till the end of maintenance. For transplant, some people use it for 1 year post transplant. You give it and then stop it. Nobody knows the real answer. I've given it sometimes for, like, earlier I used to give it for 5 years and now, but now I've sort of restricted it to 1 year post transplant.
One of my patient almost complete pH positive patient around 18 months. So MRD positive last 6 months back. So I'm just worried. He not willing for the
That's
transplant.
bad. That's bad. He's going to relapse.
But is negative. Just do the PCR will list, so 0 RT-PCR quantitative is negative. So just want to continue. I don't know.
Okay, so you have to just keep your fingers crossed, I guess.
Yes.
Yeah.
Thank you, sir. Thank you for wonderful. Literally, really discussion is wonderful and much of learning in this discussion. Yes.
Yeah. No, we can always
Nice.
call up each other if there's any doubt, anything. You can always, we are always available on phone. So
Yes, I will. Yes, sir.
okay, any more questions?
Sir, one question from one of the attendee, junior doctor, and he's asking, how much of Inonza cycle advised before HSCT?
2 cycles, up to 2 cycles. So as I was mentioning, you initially give 1 cycle, meaning 3 weeks you've given, then you've given a 1 week break. Then you do your bone marrow and check your MRD. If the MRD is negative, transplant straight away. And how much time to give between your last inotuzumab and the transplant to minimize VOD? Nobody knows the answer, but between 6 to 8 weeks. That's the amount of time. That's the amount of time that you should give between your last dose of inotuzumab and the onset of conditioning. And if avoid using more than 2. So if you haven't got an MRD negative state after 2 cycles of inotuzumab, then use something else. But avoid giving more than 2, because otherwise then the incidence of VOD goes up to like more than 40%. Another question from Rukaya. Please suggest a typical haplo conditioning and GVHD prophylaxis for B-cell ALL. Okay, so typical haplo conditioning and GVHD prophylaxis for B-ALL. Okay, so you opened a little bit of a Pandora's box. Is a big answer. But so if you ask me, so if it's a haplo conditioning protocol, standard treatment, what most people would do is to use post-transplant cyclophosphamide. And the conditioning that can be used can be, so it can be a TBI-based conditioning, fludarabine TBI. Avoid using Cy TBI now. Use fludarabine and TBI because the toxicity is less and there's no benefit of adding cyclophosphamide. So flu TBI. TBI, how much dose? Well, we just read a paper in today's journal class in our hospital between 8 and 12 gray TBI. The difference is roughly the same. So I prefer 12 gray of TBI. The toxicity is not less and is not sort of more than 8 gray, and probably you may have better responses. So I prefer 12 gray TBI, and then post-transplant cyclophosphamide. Or now, so TBI has been the best conditioning regimen in terms of achieving a best response in ALL. But the problem is that what people have realized now over the years is that the late effects of TBI are quite bad. Especially the secondary malignancies, the incidence is maximum with TBI. The endocrine complications, the metabolic complications, diabetes, heart disease, all these things that you develop later on at 10, 15 years down the line are significantly higher if you use TBI. Pituitary failure, endocrine failures, these are higher with TBI, So people are trying to move away from TBI-based regimens and move on to, I prefer triosulfan or busulfan, any of these drugs which also penetrate the CNS quite well. You can use any of these. So flu trio and 200 centigrade or 400 centigrade TBI on day -1. And then a post-transplant cyclophosphamide as GVH prophylaxis. That's the typical thing which you use. If you ask me what I'm doing currently, I'm actually doing T-cell deplete transplants in ALL. So TCR alpha beta deplete transplants, wherein I use a protocol of rapid ATG, triosulfan, and fludarabine, and do a T-cell deplete transplant and use no post-transplant GVHD prophylaxis. And I've got exciting results which I'm going to present, hopefully a few more transplants, and I'll present it somewhere. So that is what I'm excited about, because the toxicity is very low, but the cost is, of course, of that process itself is, is pretty high. And it has got some other nuances which, which need to be discussed in a different forum. Mini CVAD plus inotuzumab, yes, can be done. It's a good idea to use that. There is data on that also. Mini CVAD plus inotuzumab. As I mentioned, chemo plus inotuzumab can always be done, especially in those who've got a high burden disease. So if you've got like a 50, 60,000, 1 lakh WBC count in the peripheral blood, then you need to give something along with, it can be just vincristine body steroid or a CVAD or anything else with the inotuzumab. Yeah, so I would use, the answer to that question, I would use chemotherapy with inotuzumab if there is high burden disease. Otherwise, refractory ALL, I would use only inotuzumab if the burden is not very high. whether alone we should use in induction or combine with mini CVAD. So in induction, yeah, so that's what I just mentioned. I think I answered that question. Yeah.
So in T cell deplete,
Yeah.
sorry, in T cell
Yeah,
deplete, sir, the chances of GVH will go down.
the chances of GVH are extremely low because you typically develop only grade 1 or grade 2 GVHD.
So what about the relapses then in these cases?
So, I have looked up a paper in AML at least, adult AML, a good paper, and there the relapses are not at all different. And my personal experience is also the same. They go smoothly and the relapses are not different. So I don't think that's really the case. Ultimately everything depends upon a good graft versus leukemia effect, which if you develop, then nothing happens. So the NRM particularly is much less. NRM is much less. And that is something which at like in individual centers have individual problems, but in my center we have so much of CMV and Clostridium difficile infection that I dread immunosuppression post transplant.
Okay.
Yeah, and I have my own sort of strategy where I add back, I do the T deplete transplant and I also add back a small DLI to ensure a good engraftment and to ensure a good GVL effect. I add 10 to the power 5 unselected TCR alpha beta positive cells along with the graft.
So when you do
that
that,
helps in. Huh?
When you will do DLI,
co-infusion. So I'm selecting out, doing a TCR alpha beta transplant. You're selecting out the CD34 cells, and a huge amount of those you're giving, like upward of 15 into 10 to the power 6 CD34 you're infusing. Along with that, because you're depleting all the lymphocytes there are no lymphocytes along with it. So you want to give a little bit of lymphocytes along with it. You can control the amount of lymphocytes you're infusing with the graft. So I typically give about 10 to the power 5. So as if you're giving a small DLI. So I co-infuse it with these cells. And
interesting.
and that way the relapse rates, this is not my own idea. This has been done in the past also, but by a few people. So that will ensure better engraftment, because primary graft failure is otherwise quite almost 15% in T deplete transplants. So I don't know, NRM is less, but it has its own problems which we are learning. So I won't say that everybody should jump in and start doing T deplete transplants. Yeah, but it's an interesting thing which I've been toying with.
And so that cost, how much you're getting for TCR depletion?
48 lakhs.
Oh. It's every time we hear to you and we learn something new, sir, from you.
Oh, thank you. I'm flattered.
No, it's really, whenever we had a panel discussion and when you're, every time something you come with some innovative ideas. Great.
Okay, one more interesting idea that I have come with for one of my patients now is that she's a relapsed ALL and she's got, we've been giving her, so she's developed a CNS relapse, 4,000 count. So I'm giving her intrathecal DLI. Intrathecal DLI also.
Great.
That's another interesting thing that I'm coming up with.
Let's see how she's post-transplant, sir.
She's post-transplant relapse, systemic relapse. So we gave systemic DLI. Now that she's got into MRD negative state, we used inotuzumab to get her into MRD negative state in the peripheral blood, and then we gave her DLI. Second DLI we gave. Everything's good with the blood. Now she developed a little bit of neurological symptoms, and there's 4,000 counts in the CSF. So obviously inotuzumab doesn't take care of that disease, and so to take care of that now, we got to give her triple intrathecal, get that into remission, and try and giving her intrathecal DLI and see what happens.
Okay.
This has also been tried by somebody. When I looked up this, somebody else has already tried it.
No, but very interesting. And inotuzumab, how many cycles you are going to plan, sir, for this kid?
No, we gave her 2. After that, she went into MRD negative state in the blood. So no more inotuzumab. And
again, how will you monitor for MRD?
So marrow MRD, and CSF. So we just have to intermittently keep checking and see, tapping the CSF and see.
No, so, sir, marrow MRD again you will repeat after a couple of months or how?
Yeah, every 3. I'm doing it every 3 months now. But let us see what happens to the CNS disease.
The one concern is whether it can cause any CNS problems, DLI, giving DLI into intrathecal, like
yeah, that's a good
meningitis,
question.
inflammation.
No, meningitis तो नहीं होगा, because you know ultimately the same cells do go into the CSF also. Whatever you give into the blood, that is they are the ones which are going to go into the brain and take care of that disease. And so they always penetrate the CNS. So here
The question is, yes sir.
Yeah, so you're not going to inject blood. You'll have to do an apheresis. From the apheresis, something like a 0.25 ml is what you would probably need to inject.
Right.
So you infuse a lot of lymphocytes.
Yeah, my concern is that we are giving DLI, so there are some lymphocytes which are which may be autoreactive. Suppose we inject via peripheral blood or systemic injection. So in that case, those autoreactive cells, they don't directly come into contact with brain. So more likely than not, because of GVHD suppression, GVHD and prophylaxis, those cells they don't survive and don't go into CNS. So if we directly do a shortcut, whether
Yeah, so I don't know the answer to that. I've looked up 2-3 papers where this has been done, and they didn't face any such problems. But I agree that's a problem. But what is worse than dying ultimately of CNS disease? So whatever inflammation, whatever you want to have, let's see, it's better than dying of the disease.
I'm asking this because I had suggested the same to Kannan sir during my residency. So why don't we do that? So he said you cannot do that. It can cause CNS problem.
You can do it. You can do it.
Right, sir.
Okay. Okay. Fine. I think we are close to 9 o'clock, so we have. I think. Is there no other questions? Is this enough?
Yeah, no questions, sir. I think all question answered. And I think almost after the slides, 20-25 minutes to listen to the experts and you, everyone. It's a very good learning, sir. Very good discussion, I must say. I think our colleague, I think we have our RBM, sir.
Hello, sir. Good evening. Nitin
Hi.
from Bombay, sir. I'm the West RBM for Pfizer. I can see Dr. Akshesa unmuted. Sir, do you have something to ask?
No, I think everything has been covered.
Sir, with your permission, I'll give a small vote of thanks.
Thank you, sir.
Before that, sir, I will check with Rukaiya whether we have any questions in the chat box. Rukaiya, do you have any questions in the chat box and the attendee link?
All questions are answered, sir.
All questions are not. Okay. Thank you, Rukaiya. So, on behalf of Pfizer, I thank Dr. Samil Menankari, sir, for wonderfully moderating this session and patiently clearing all doubts of the panelists as well as the questions that were dropped in the chat box. And I also thank Dr. Ankit Riyani, Dr. Akshesha, Dr. Varun Bafna, and Dr. Ashok Rajoria for their valuable time and sharing their insights from the clinical practice on the dais today. I'm sure this discussion would have added value to your scientific in clinic practice, sir. And I'll also thank close to 25 hematologists who attended this meeting via a separate link and for taking time out. And I'm sure this discussion would have added.
Okay. So it was actually, I was a little in the beginning when the
program for Inonza that we run. So, sorry, sir.
No, I told some of in the beginning there was a this thing saying that only those who have been invited should be attending. Those who are, and Pfizer will cancel those who are not invited. So I told my students to attend, but I told them later, okay, don't attend because Pfizer has said not to attend. Okay, chalo. Anyways.
No, sir. It is not like that. HCPs, non-HCPs who attend the meeting. Your colleagues can definitely join the meeting. So this is not like that.
Okay.
So to prevent we have a privacy policy in place where the discussion should not have attendees which were non-doctors. So, sir, we have a pregnancy vial, sir, which cost is around 2.5 lakhs of rupees, 3.3 lakhs of rupees, sir. And we give the 15th day dose free, the third dose. One day one and two in India, sir, relapse and refractory B-cell ALL and Philadelphia positive B-cell ALL who has progressed on at least one TKI, sir. And only in adult patients, sir. We don't have the approval in pediatric patients, and also we don't have approval in Unza, sir. So that was it, sir. I thank everyone for spending their time today with us and for a wonderful scientific treat. I'm sure everybody would have enjoyed the scientific treat that was there for the last 1.5 hours.
Thank you.
Thank you, sir.
Thank
With this,
you.
we can close the meeting.
Thank you.
Thank you,
Yeah,
sir.
thank you very much. Yes.
Bye.
Thank you so much.